We're going to change tack now and look at allergic rhinitis. Is it more than hay fever? So please, over to you.
Look, it's always a pleasure to come up at this point in the talk because there's probably a few people in the audience who would like to move away from the lower airway and we'll talk about the upper airway, a bit of a change of approach. I'm going to talk very much with the same spirit that I think our panelists have just discussed with us. And this is this concept that much of what we see are patients who present with acute intermittent symptoms. And although there may be some chronicity in the underlying disease, they themselves don't often feel it. So I'm often asked to talk about chronic conditions, but here I'm going to have a slight bent on the idea that what we see often is patients with acute symptoms. So let's go through this now. There's my disclosures, none of which really affect the content of my talk. I think whenever I give a talk, I usually like to start out to make it very clear that I'm going to talk here about rhinitis predominantly, and rhinitis is really a condition of the nasal cavity or nasal airway, and it's very different to sinus dysfunction. So sinus dysfunction means something very different to me. People who have rhinitis and a nasal airway problem, they have problems with vascular congestion, secretions, glandular hypertrophy, and they often get jelly-like changes to the nasal passage tissues that bring about their symptoms. And I think this is very different to patients who have true sinus disease. In sinus disease, they get mucosal inflammation of the sinuses with remodeling, and sometimes your little polyps form here. You can see that the nasal airway is not nearly as congested, but they have changes in their sinuses. And unfortunately, when the sinuses become inflamed like that and mucus starts to get trapped, they then get these sort of secondary infective phenomenon on top of it. And so that I really see sinusitis as a very separate entity to what we're focusing on today, which is really a rhinitis. Now, there's many people here in the audience who might look at this image and say, well, I can pick that person out. They've got terrible turbinate hypertrophy. They've got the classic swollen turbinates. And I think this is true. I think if you were looking at someone's nose and saw this, even the lining there is a little bit orange peel-like. This is classic sort of turbinate congestion that comes with long-standing inhalant allergy. But really, when someone presents like that, they're very obvious. A medical student can pick out that. There's more subtle signs, though, that we start to see in allergic patients. And this is one of them. And I'm going to introduce you to this early. This is turbinate head edema. And you can see it just with an otoscope. You can see here how the head of the turbinates become a bit jelly-like. And you can see it here on the other side in another patient. You almost get this almost polypoid-like change coming off the turbinates. This is not nasal polyposis. This is really just inhalant allergy. Now, I've shown you some really good examples here because many people walk around and their nose looks like this all the time, even though they may not necessarily have a lot of symptoms. And I'll explain why that's important in a moment. Now, we've done a little study to show, look, this is what the turbinate should look like when you look in. And down here, you can start to see this focal jelly-like change, little nubbins of jelly change. Then it becomes diffusely swollen, and then you even get this polypoid swelling. Now, you can see this just with an otoscope. If you spray the nose with decongestion, have a look in. You don't need fancy endoscopic examination to see this. And if you see it, the positive predictive value that that person has an underlying inhalant allergy is incredibly strong. It's not necessarily sensitive, but if it's there, it's a clear marker that you have an inhalant allergy sufferer. Now, if you said to me, what other changes can you see or have been validated over the years? So look, just when we published on some stuff, I found that many years ago, this Italian group had touched on this. They looked at some children and showed that once again, if you looked in the child's nose after decongestion, if you saw this swelling of the middle turbinate, that gave you an odds ratio of more than 5 times likely to have allergy as opposed to a middle turbinate that clearly wasn't touching anywhere. And the same was true for the inferior turbinate. If you look in and can see into the inferior meatus, so there's a bit of a gap here compared to where the asterisk is here, this is a sign of inhalant allergy. And so here's a great features of that every person who has a simple otoscope can look in the nose, and if you see a swollen middle turbinate and a swollen inferior turbinate with loss of that meatus either here or here, then this is a sign that you have allergy. And these groups did do sort of quite complex logistic regressions. And it's quite amazing, even then, the only thing that really highlighted inhalant allergy were these turbinate changes. So we really make a big deal of that now when we examine patients, and amongst other changes further back in the nose, but I'm not going to touch on those today because I really don't think they lend themselves to simple anterior rhinoscopy. You really need an endoscope to see them. But these changes that I've shown you today are ones that everyone can take away and utilize in their practice. The next thing that comes into my mind when someone walks in the door and I'm trying to work out whether they have significant inhalant allergy in their nose is their age. So this is Australian data looking at rhinitis sufferers versus CRS sufferers. The reality is that allergic rhinitis compared to young groups becomes increasingly less common as we get older, and chronic rhinosinusitis becomes increasingly more common. So it is a condition still of younger people. So if someone comes in and sees me complaining of congestion and they're 40 or 50, the chances that they have an underlying rhinitis is very uncommon for the first time. And when you look at sort of an ordinal regression here with a whole lot of other factors involved, you can see up the top here that relative to being 60 years of age, having allergic rhinitis is still a condition that is of young people here rather than being of a middle or older age. Now, there's probably nothing new about that for many people who know a bit about inhalant allergy, but this is very true. If you have a child that has some sort of ENT complaint, the fact that they need to see an ENT surgeon in itself is a marker of inhalant allergy. So when children went and presented to an ENT practice in Italy, the reality is that almost 2/3 of them, or 50 to 60%, had allergic rhinitis. And once again, they showed this middle turbinate congestion being a great sign. They also showed that large adenoids, just having them means that you've got a very good chance of having an inhalant allergy. They did look at other factors, and there's some typical players here, like if you had a family history of atopy or asthma as a comorbidity as a child, that these are all markers of being atopic or allergically sensitized. So that's something else to consider. Any child who you think needs some sort of ENT care alone must have inhalant allergy raised as, is this a player in their condition? Now, I'm going to touch on this. So this poor reporter is discovering the other phenomenon that plagues acute rhinitis symptoms and acute upper airway symptoms. It's not always allergic. So cold air, environmental triggers can produce symptoms in the nose. And we refer to this as nasal hyperreactivity or hyperresponsiveness. And although we may all here be familiar with the allergic phenomenon in the nose, there are a bunch of environmental factors that can trigger the nose and produce the response that we see in that young poor reporter. Now, we refer to this as nasal hyperreactivity or nasal hyperresponsiveness, and it's driven by nerves. And, you know, I'm a surgeon, so it's got to be made very simple for me. So we have a set of sensory nerves that are our afferent input. They pick up those environmental changes. And then we have an efferent supply of output that produces the congestion and watery nose response. Now, if I had to give you then a very simple slide to show how this reflex works, here's my nose. Now, if you said to me, well, you know, when you go out for a jog in the cold morning air, or you go into a smoky room and you immediately get a sneeze or symptoms, then what's happening there? Well, underneath is a bunch of nerves. And the afferent fiber mediates pain and sneezing. Now, this is important. It's probably part of a teleologic response in the nose that if we go into a dusty environment, we start sneezing immediately. It's not necessarily histamine driven. And it's a neurogenic response. We think it's a protective mechanism in the airway, but it's mediated through some of the trigeminal fibers. And this is one I heard someone talk about smoke in the air. You know, you will see many people in Australia when there's bushfire smoke will say, oh, you know, smoke's playing up with my sinuses. I've got sinus disease. And what they often describe is sort of a bilateral pressure and congestion and pain. And then 2 or 3 days later, when the smoke's gone, they're feeling well. Well, what's really happening there in a lot of these patients is they're simply getting an environmental rhinitis, a neurogenic rhinitis. There may be an allergic component to it, but a lot of it is actually mediated through these nerve endings. And that's why they feel they're getting sinusitis, and it goes very, very quickly. The output obviously gives you the sort of watery nose response as well as some degree of congestion. And so this is a very simple neurogenic sort of reflex arc if you're going to think about it, because I'm going to touch on some of the treatments that have been described here. Let me have a look. There we go. We moved on. Now, what mediates these nasal hyperreactivity? Well, it's a very different pathway to simple allergy. And so, obviously we are familiar with what are the players in IgE-mediated inflammation of the nose, but what forms the neurogenic pathway are these other players here. And this is why simple monotherapy with corticosteroids really doesn't have a role here. They don't mediate this neurogenic pathway. There is some evidence that some of the newer combination treatments, such as Dymista and Ryaltris, because they have azolastine and olopatadine, they do have some effects on this pathway. So you'll see some trials come out in both of these products where they touch upon a mixed group, we call it, of mixed rhinitis. It's not just a clean allergic rhinitis, that there is an effect size here. But what is confusing, and I want to make this very as straightforward as possible to get rid of this gray area, is that patients are rarely one or the other. So you do have, I heard someone talking about pure exercise-induced asthma. We do see some patients who have pure neurogenic rhinitis. And this is what we call cold air provocation testing. It's how we pick out that neural hyperreactivity. Now, what is fascinating here is that allergic rhinitis patients, if you have untreated allergic rhinitis, you will get environmental reactivity. So in an untreated allergic state, most people have a degree of neural hyperreactivity as well. So they respond to things in the environment. So just simply asking people whether they respond to perfumes or cigarette smoke or cold air isn't enough to help you separate out a neurogenic rhinitis from an allergic rhinitis. It's just that in the neurogenic rhinitis, there's no other condition going on. Whereas in allergic rhinitis, if you actually treat their underlying allergy, their actual nasal hyperresponsiveness actually goes away. So that's just a take-home caveat there. You should be careful about making it too simple. It's just that hyperreactivity comes with an untreated response. But if you say to me, how do we make the diagnosis then of non-allergic rhinitis? Well, if someone gets their symptoms later in life, they lack asthma, conjunctival, or skin symptoms, which you would expect in an IgE-mediated disease. There's no seasonality, and it's certainly not an animal or cat-induced. And there's no family history of allergies. And the symptoms, in particular, influenced by things like perfumes and fragrances. This is what we call the Cincinnati Irritant Index. That's the CIR, that list of environmental factors I showed you. Then you have a 95% chance that this is a non-allergic rhinitis. And they're the sort of flags you want to look out for. Someone who says they'll fine their whole life and then in their 30s starts to get a funny reactive nose, then this is probably, it's more a neurogenic or nasal hyperreactivity than it is an allergic phenomenon. And of course, when you look in their nose, they look the neurogenic sufferer like the patient on the left here. There's no congestion of the middle meatus or inferior turbinate. Whereas now, with your new knowledge about what to look for, you can see how the turbinate is very congested. When you look up here to the middle meatus, there's edema and contact. This is an allergic sufferer. And I can tell you, both these patients came to me with no regular symptoms. They only get flares, and they complain of symptoms during the flare. And one person's got this adapted baseline state here of chronic allergy. Now, what about post-viral? So just like the lower airway, in the upper airway, viral events create an inflammatory response. I constantly see this in young parents and young adults who think they have sinusitis. So here's an acute rhinitis as a result of a viral event. Sticky secretions. There's not hypertrophy. This person does not have underlying allergic rhinitis, because you can see they don't have those changes. Very sticky back of the nose here. And for many years, I've been doing PCR tests here to show that these patients aren't getting an allergic event. They're not getting a bacterial sinusitis, but in fact, it's just a viral exacerbation, just like we see in the lower airway. And this is actually just a typical respiratory coronavirus. No, it's not COVID. This is back in 2018. It's just demonstrating a positive PCR result in a patient who's insistent that they're getting sinusitis, and in fact, they have an underlying rhinitis condition being exacerbated by viral events. Now, if you asked me how often do we get viral events, in childhood. You know, it's very common. You know, this is Australian data looking at 500 children in Melbourne. We know that 96% of these are going to be viral in origin. So we know that most respiratory events in children are viral. And from similar data, we know that they're going to last a week to 10 days. So simply just having something last a couple of days doesn't always make it a viral event. And these are the numbers. I'm going to go back here, the number of episodes per year. So you expect the children to get it about 4 times a year, and therefore the parents will get it a similar amount of time. So that could mean 40 days of the year, they have upper respiratory symptoms related to viral events. And if you have an underlying allergic condition, like those noses I showed you, well, then when you get a viral event, it feels a lot worse. It's like pouring petrol on the fire. And this is the thing that I think a lot of patients have problems with, is that they have an underlying allergic rhinitis and then they get a viral event. They're not that symptomatic from their allergic rhinitis during most of the year, even though they have a nose that looks like it. But when they get their virus, that's when they really complain of symptoms. Now, rarely is it bacterial. And I love to point this out to most people here in the audience, that potential bacterial sinusitis is almost always a unilateral disease. It's very rare that people get bilateral bacterial complications. Very, very rare. So, and I know there's probably some people here listening to my talk and thinking, golly, that means that's 80% of the patients I give antibiotics to. And that may be the case, unfortunately, that we probably do overprescribe antibiotics in patients who just come in with very bilateral congestion, bilateral mucus, probably not a bacterial event. Now, what is true though, is that if you have coexistent allergic or rhinitis or non-allergic rhinitis, it ensures that these viral events are worse than the patient's colleague or friends or other family members. Now, I just want to touch on this because this is what our offices all look like now with social distancing. And back in 2016, I tried to bring home this point about, you know, preventing viral exacerbations. You know, it was something we didn't touch on enough of. I mean, we talked about accepted hand washing. Social isolation always was rejected about the perceived necessity and efficacy. What's beneficial is actually hand washing. And there's 9 case control studies at that point back several years ago showing that things like masks for the carrier were very useful. But it's amazing that we've had finally a pandemic to bring this home, that this is actually something that we need to start adopting to prevent these acute flares of underlying respiratory conditions. And I think this will help. And this is my son demonstrating a mask, that maybe this will become socially more acceptable. And he's a lot older now than that. Now, but I just want to touch, I would say throw in one slide about COVID. You know, for us, there is a bit of talk about smell loss. You shouldn't really get smell loss in allergic rhinitis until very end of the condition. But you can get it early in some viral events. And so these patients looked at, my friends in the US looked at 1,500 patients coming in with flu-like symptoms. They separated them into COVID positive and negative patients. And they showed that smell is very affected. So if you do have someone with smell loss, and obviously that comes with taste or flavor of foods, I think you do have to consider that they may either have another condition or they've got a very olfactory directed condition or exacerbating factor like a coronavirus, which is thought to affect the olfactory system early in the piece. And they had an odds ratio of 10 if your smell was affected, that you're more likely to have COVID here, as opposed to a sore throat, which was sort of negatively correlated with having COVID. Now, but I'm going to touch on my last minute or two here just to talk about, but doc, I got sinus. I keep on saying I've got sinusitis. I'm going to show you just a couple examples then of when sinusitis is not sinusitis. This is a person who doesn't have sinusitis. They've got inhalant allergy. And I'm going to touch on this because what's going on in these patients is they get this jelly-like edema, which we saw here, I demonstrated to you before, is a marker of inhalant allergy, and it gets bad. So here's a patient who has it badly, and their sinuses are fine. There's the jelly-like edema. The jelly-like edema starts to stick into the sinuses, see there? And they sometimes get a bit of mechanical dysfunction, but they don't have sinusitis. They just have this jelly-like edema, and it can look like some giant polyp in the nose, but then when you go back, their actually sinuses are normal. So this can be very extreme. So we do see some patients who have this really thickened tissue around the entrance to their sinuses. Their scans look like this. This is not sinusitis, believe it or not. This is actually an exuberant inhalant allergy, not sinusitis. And we refer to this condition as central compartment atopic disease. And the reality is that it's sort of been recognized for a while in our profession as the black halo sign. So someone gets this central thickening here where all the sinuses are normal around it. And it's even been on textbooks in the past, but it hasn't really been separated out into its own condition until just recently. So here we are now with the EPOS 2020 classification of CRS. They actually have central compartment atopic disease as this very specific inhalant allergy driven phenotype of what we still left it in the concept of sinusitis, but its underlying pathophysiology is really just this really exuberant inhalant allergy. Now, that means patients look like this. They don't really have sinus disease. And there are patients here, such as this ENT surgeon's son, who has significant inhalant allergy. They've already had a turbinate reduction. Then they become very symptomatic. Their approach here is try to cut the allergy out. That doesn't work. And then many years later, I see this example of someone who's got central compartment sinus disease. They've got a bit of mucus trapping on one side. A couple of months later, it's the other side. Sometime another month later, this is an immunologist's daughter. She has bilateral congestion. And then she gets sinus surgery. And 2 years later, she's still presenting with the same symptoms. And that's because what's really going on here is an exuberant allergy. So be very careful about interpreting sinus changes here, especially in that young or high-risk patient for having allergy. So what do we do here when it is allergic rhinitis? So we know that the nose doesn't look like this. You have to identify it. They get those jelly-like changes, this congestion. And we know that here in this situation that it's not all about histamines. Although we have antihistamines to treat the histamine component, there's so many other components here. And this is why we have to rely on corticosteroid. But we will often give corticosteroids acutely in much higher doses over a few days to manage acute events rather than simply just telling patients to use it as a once daily treatment ongoing. And this is where combination treatments, they bridge the gap obviously across both sides here. Now, those combination therapies have entered the ASCIA guidelines now. So really they're introduced very early on actually and especially this group here, which is intermittent and moderate to severe. So patients who have severe intermittent rhinitis, I really hit them hard with things like combination treatments. We do it early. You can do a step up and step down approach. And examples of these combinations are like fluticasone, azolastine, or mometasone and olopatadine. And there are other ones that are going to be coming out over the next few years, such as decongestant combined fluticasone. Then we will start to see these entering our realm of acute or PRN type treatments. Now, I'll be careful how I say PRN because it is actually really an acute treatment over a couple of weeks. And we may even see dosing regimes like we do with dermatitis that are more than just simply once a day. I personally off-label use them more than once a day for a few days to manage those acute intermittent sufferers, but we may actually even see those regimes come into TGA approval. Now, just to touch on other treatments here, capsaicin, phenol, this works on pain and therapy. Ipratropium or Atrovent works on the watery or the afferent pathway. UV light therapy and chromoglycate, they obviously work on eosinophils. We don't use these very much in Australia. Leukotriene antagonist, turbinate surgery certainly is useful, but very unidimensional. And of course, in Australia, we're very lucky to have some great oral immunotherapy agents, which I think we need to talk about early on in the piece. And although we do talk about double dosing of antihistamines and other features, probably the most useful slide here is this concept that we have a visual analog score that breaks moderate to severe in terms of mild. And it's really 2 weeks is all we give patients before we assess them again, not months and months. An untreated allergic rhinitis can impair your ability to drive a car. It impairs school performance. So it's worth getting on top of in these patients. So in my conclusion here, and just to stay on time, inhalant allergy in the nose is often an adapted baseline state. It does make it, as Peter suggested, it makes it incredibly difficult then to tell patients to use a treatment all the time. But they need to be interpreted when you look into someone's nose. So you have to understand what's happening in the nose, and then before you look at their radiologic mucosal changes, because that'll help to separate who really has allergy and who doesn't, and who has sinus disease and who has simply just inhalant allergy. Now, it's very common that these untreated allergic patients who really don't complain of many symptoms most of the time, that they get this mixed hyperreactive neurogenic response in their nose, and that viral exacerbations are a major cause of morbidity in these patients. They really do complain of symptoms, often only with viral exacerbations. It leads to a lot of unnecessary antibiotic exposure, a misdiagnosis, and obviously for me, it avoids a long-term option here of introducing long-term treatment, because these patients often end up buying themselves turbinate and sinus surgery, but it's rarely successful if the underlying atropic drive is not modified. And that's why I think it's the chance of introducing immunotherapy early into the place, and especially in anyone who thinks that they might want to have surgery on their nose should consider immunotherapy if they have an underlying allergy to go with it. And this applies for both children and adults. And look, I thank you very much for your time. And I know I was a little bit rushed at the end, but I wanted to make sure we had a few minutes for questions. Thank you very much.
Thank you very much, Richard. And as ever, that's an excellent, clear presentation. You're as clear virtually as you are face to face. So that was wonderful. I wanted to just ask you a question to start the ball rolling about actually asthma and allergic rhinitis. So I should have been in London today, actually at the IACI meeting, and we are still presenting it just virtually. Some data on combination fluticasone and azolastine, dimista, in patients who had asthma. So this is using our large UK database with just it's got about 10 million patients in it currently, and we looked at patients who were given dimista as part of their management for their allergic rhinitis, and looked at their asthma outcomes the year after versus the year before. And what we actually saw was really quite substantial improvements in asthma control. Now, whoops, gone too far. So I've just shown I can't use the tech properly here. Let me just pull that back up. While I'm pulling the slide back up, though, what do you think? What do you think's going on there? Do you think we actually are improving the asthma, or do you think there's simply people are misinterpreting nasal symptoms as asthma symptoms, or what do you think?
No, I think we absolutely are improving their asthma. I mean, I think those early studies that looked at the concept of shared airway inflammation is a true one. I think what we're seeing, I think, for many asthmatics is that if they really do have significant asthma, often their symptom profile is dominated by their lower airway. It's what's going to cause the most morbidity for them. And they have, especially with the allergic ones, they have a primed upper airway. And so their upper airway is often untreated. It's primed. It looks like those videos that I showed you where everything's jelly-like, and that's their baseline state. And when they then get a flare, whether it's a viral trigger, an allergen-driven trigger, they get probably a lot of cytokine media release into their bloodstream, and that then makes their asthma a whole lot worse. And so I do believe that's probably the mechanism. I mean, whether or not you think that just having a blocked upper airway really makes your asthma worse, I think it's questionable. But I think that's really what's happening. And there is some form of reflex response, but I don't think that really explains, the interaction we see between the upper and lower airway effectively.
Okay, thank you. Kerry, what were your reflections from Richard's talk? What would be the take-home message for you, do you think, for the primary care docs?
Yeah, it was a great talk, Richard. Absolutely fantastic. I think we need to be on the lookout the whole time for these patients with allergic rhinitis and trying to differentiate them out. I'm not quite sure whether my otoscopic skills are quite that good to be able to really see up there, but those pictures were pretty impressive. I suppose one of the challenges I find is you diagnose somebody with allergic rhinitis, you know how, what treatments to offer them. Yes, the first time you see them, they go and get what you prescribed, and then you see them again 6 months or 12 months later, and they come back again with the same symptoms again. and lo and behold, they've only taken the medication for a couple of months, and then they couldn't be bothered going back to buy it again, and they've forgotten that that's what you told last time, even though you thought that you didn't emphasise that. So, it's just like we have a problem with our patients with asthma taking their regular preventive therapy. Trying to get these patients to take their therapies for allergic rhinitis seems to be even more challenging, and cost is often an issue, and access, and there's one more thing they have to buy.
Sorry, Richard, Cameron.
Can I answer that? Because that's a really common thing that I think Kerry's touched on. I think to me, I think it's so important to get out with a patient what their goal of treatment is. I think if they come and see you and they have allergy symptoms for a couple of months every year, and they just want an approach to how to manage it, it's totally appropriate. You just hit them up with how to do pharmacotherapy effectively during those few months in which they need symptom relief. But the minute someone comes to you complaining of long-standing or perennial year-round symptoms, I think it's almost incumbent upon us, if we're going to talk to them about pharmacotherapy, where they're going to take every day, that you talk to them about the long-term strategy of where is that atopic management going to go. And that's where I talk to them almost one of their first appointments. And it's a little bit different when they come to me, but I talk to them about immunotherapy and immune modulation long-term at the very beginning, if I'm going to recommend something, for over 6 or 12 months. Because I listened to your stories, I'm going to see them 6 or 12 months later. I was thinking, you missed the boat of having 6 or 12 months of immunotherapy on board. You could have actually advanced their actual whole disease process in that time. And I actually really do push in those long-term perennial patients an idea of what are we trying to achieve long-term. And I think that's what we should do more and more now at a primary care level.
One last question before we break for lunch. Apart from something like Dymista, what else can work in non-allergic rhinitis?
Yeah, so non-allergic rhinitis, or at least when it's a mixed condition, but there's a very strong nasal hyperreactivity approach, we do give capsaicin as a treatment. So capsaicin was available in Australia as Rinar. It can be compounded. It can be purchased as there's a sinusol. There's a couple that are available. It is a one-off treatment, so you'd use it until you no longer feels that the capsaicin stings. It's actually quite a good treatment. So that especially for patients who get sneezing and pain, this is very important. Patients who just have a watery nose, so say their watery nose is problematic when they go for a jog, or if they go out to dinner, or they just want to avoid a situation where their nose waters, ipratropium works very well. But it's a hopeless medication in the sense it only lasts a few hours. So it's good as a preemptive treatment, half an hour before you're about to go for a jog or do something, but it's not going to last you the whole day. And look, I do things like videoneurectomies for patients who have intractable watery nose. And so there are other treatments that are available. So just giving you a feel of it there, that's the zone of what I do. Now, someone asked me, say, okay, Richard, what after Rinar or capsaicin treatment, if they get a desensitization, do I maintain them on anything? So there are actually a couple of products that are over the counter that are full of trigeminal stimulants. So pine oil, menthol, tea tree oil. One of them is called Ponaris. It's available. You can buy it on eBay or Amazon, and it constantly saturates and floods those trigeminal receptors. And a lot of hyperreactive patients will take things like this with great success. So if you said to me, how do I maintain people after a capsaicin desensitization, that'd be another approach.
Thank you, Richard. There's a load of questions online, so I might ask if you wouldn't mind having a go at answering some of those for people. If you have a second, that would be really appreciated in the Q&A bit.
My pleasure.
Thank you.